Good afternoon. My topic is the managing the cataract surgery with the coexisting lens challenges. There are multiple challenges we face, but we will going to cover few of them. Normal surgery is a safe surgery, but we have some of the cases where we need an special precaution, and for that a preoperative evaluation with the aberrometry, slit lamp biometry, slit lamp, AIOS2025 is important. One of the most common is the posterior polar cataract. Typical circular defect, cookie cutter defect is found at the end. I will go directly to the surgery. Only thing, sometimes you can stent this, make a good mid-size rexis. Sometimes you have to put the lens on the rexis. Avoid hydrodissection, hydrodelineation, making a what hold golden ring without rotation. Avoid sculpting deep and try to remove the lens matter as much as possible, pulling the cortical matter and lens fragment toward the central region, and you can easily remove the lens and put the lens. Another important is the pre-existing posterior camp rent. You can see that we are able to see that rent is already existing. Only thing, we have stent the lens rexis. Will first one. Then removing hydrodelineation, low power, low phaco, to avoid to extension of that pre-existing capsular rent. Pulling the cortical matter towards the center is the important thing, so that the rent will not, and using the good viscoelastic behind this matter, so that the fragment and the lens matter will not fall down in the vitreous cavity. So removing this, now we have the rent, doing the good anterior vitrectomy with the help of tricot, so that you can detect that the vitreous stent, and then we can put the intraocular lens, able to put in the periphery, and the remaining capsular support. You can say that the rent is still the same, and we are able to 3-piece. For this, a single piece lens is not suitable. Then we come to the subluxated cataract. This time is short. I will go to the one of the video where we stent the capsule, hydrodelineation. Now we have to see that lens is moving, so we use the capsular hook so as to cover the hold of the capsular bag, and once we have the good hold to capsular hook, sometimes you can use the iris hook also, but you have the special capsular hook for that. And once you have a good hold on the capsular bag, you can comfortably do the phaco and the low power and low flow mode, and removing this. Now bag is still weak, you have to put the CTR and suture it. So we have sutured the CTR. We'll skip that the 6 o'clock and complete the surgery. This one of the subluxated cataract. We can use the, I just wanted to show the iris claw in this. Once you are done, you can very well put its iris claw is very easy. And the same with the hypermature cataract. using the tripoint glue to stand. Good viscoelastic, especially I use viscot because it has a retentive tendency and it give a good pressure on the capsular bag, so you can do the Rexis very well. Instead of Elon GB or something at P, I prefer viscot in this type of cases because Elon GB and Elon just come out because I do with the forceps the Rexis, and it is very easy to do with the forceps in this type of cases using the good viscoelastic material, especially the viscot. Then the rest of the job is quite easier. You can do whatever the grade of the nucleus, complete the surgery. In the hard cataract, you have to use the good viscoelastic central, and you need a larger Rexis in this because the manipulation is more, so you require a larger Rexis in this case, and hardly half minute. Increase the power, repeated use of good viscoelastic and chopping, taking care that you will not give a good more stress on the zonules, and repeated use of viscoelastic, taking, you can see that it is hard brown. Repeated use you can release, and so in a short, meticulous and appropriate surgical procedure can give good surgical outcome even in difficult situation. Thank you.
Thank you, sir, for the nice, wonderful presentation, nice videos.